Hello everyone, my name is Ananta Addala. I'm a pediatric endocrinologist at Stanford Children's, and I'm here to talk to you today about quantifying inequities in type 1 diabetes care. As a brief introduction to myself, I will take you back to a few years ago when I was a little girl, and I remembered growing up and noticing that people weren't always treated the same. I noticed that people were treated differently if they were by their gender. I noticed that they were treated differently by their income level, by their class, by the color of their skin, and this was all in my small Indian village. And I remember pestering a lot of grown-ups trying to understand why this seemed to be the case, why it was that although the right thing to do seemed to be to treat everybody equally, that isn't actually what happened. And a few years later, I had learned that I was going to be moving to America, and I had heard that America is the land of opportunities and a place where I can really see things being done differently. And I remember specifically that I was having an expectation that this discrimination, as the word that I know it to be now, by gender, by skin color, by income, by any number of things that I'd observed as a little child, I was expecting for it to not be here in America when I moved, and had the rug kind of pulled out from under me when I realized that inequities and discriminatory tendencies had their root not just in India where I grew up, but also in America. And that really has laid the foundation for why I do a lot of the work I do. It really is because I spent much of my early childhood, teenage years, early career trying to figure out first why the inequities exist, why differential care, why differential treatment exists in our society, and more importantly, what it is that we could possibly do about it. And so with that, I'm going to launch us into our first concept, which is something that the Institute of Medicine back in 2002 had laid out when they published their definitive report on the inequities in healthcare. And this is a theoretical figure that I find very helpful. And on the y-axis here is the quality of healthcare. And on the x-axis are just two broad categories, non-minority and minority. And here, minoritized individuals can meet a number of classifications. They can be by race, ethnicity, they can be by socioeconomic status, they can be by gender, they can be by ableism. There is just a myriad of ways that people are in the minority versus non-minority group. And the Institute of Medicine noticed that there is a difference in the the quality of the healthcare that they receive. And they specifically call out the difference between a difference in healthcare delivery versus a disparity. And they say that the disparity really sits in the healthcare systems and the environmental factors, that is how healthcare is delivered, and then underlying discrimination, bias, stereotypes, and that's disparity. But however, clinical appropriateness as well as patient preferences do not quantify as a disparity. Now you will see that I have jerry-rigged a few red lines in here to suggest that I have been interested in understanding whether this disparity doesn't just stop with the healthcare system and discrimination, but in fact extends into what we as clinicians feel is appropriate and what patients perceive to be necessary, and how unintended biases can really play a role in that. So that's one important kind of fundamental foundational concept I'd like for us to have a moment to touch base with. And the second that I think is really important to discuss before we really dive into the nuances of type 1 diabetes and inequities is the very strong relationship between race, ethnicity, and socioeconomic status in the United States. These are data from the 2020 census, where you can see that there is a notable long-standing, right, so these are approximately starting in 1965 onwards, trends in income level by race, ethnicity. And these data are mimicked in the pediatric population, which is what I primarily work with the caveat that many times, although the Asian families have the lowest amount of childhood poverty, just like non-Hispanic whites, there are often more adult individuals contributing to the income. And it's important that we stop to both acknowledge 2 points. One is the strong relationship between race, ethnicity, and socioeconomic status in the U.S. simply because of long-standing generational inequities. But the second piece is to recognize that socioeconomics alone do not explain the entire disparity that's seen in race, ethnicity. And a great example of that is actually in type 1 diabetes. In 2020, Dr. Agarwal et al. Looked at the type 1 diabetes exchange registry data, and they noticed that they compared their non-Hispanic white individuals to their Black individuals, and they found that there is approximately a 2.26% A1C disparity. And for just for sort of context, hemoglobin A1C of 0.3% or more is considered notable, and 0.5 or more is clinically meaningful. So these are strides above what we would consider to be clinically meaningful. And the clever, thoughtful analysis that they did really tried to break down the components of the hemoglobin A1C gap. So that includes socioeconomic status, into which they accounted insurance, education level, the income poverty level. They looked at treatment regimen, which was pump and CGM versus not. The types of site, was it an adult site or a pediatric site? The psychological is things like diabetes distress, and ACEs. Self-management gets at health literacy and numeracy. And so you can see here that socioeconomic status certainly explains a piece of this. But one, there's multiple other contributing factors, of which diabetes technology has again, that notable 0.3%. And then there's 0.7 that's unexplained. And the question is whether how much of this is racism, because race, as we measure it, is not a biological construct. It's something that the census has come up with. It's not biological or organic in its origin. So the question is, what is the difference? Why is this unexplained 0.7%? Why does that exist? And then, so this analysis both showed the contributions of socioeconomic status, the fact that there is this unknown amount that may be in part or significantly racism that has yet to be explored. And importantly, there's this opportunity for intervention, which is here in the treatment regimen. Many in the audience know the tenets of type 1 diabetes management include finding a way to get insulin in so that blood sugars are in target range, and acute complications and long-term complications of type 1 diabetes are minimized, and to sort of know your blood sugar. And there are many ways to do this. So the insulin can be delivered through a vial and syringe. It can be done through smart pens or regular insulin pens. It can be done through diabetes insulin pumps, some of which are hybrid closed-loop pumps, some of which are standard pumps. You can also, now moving to sort of the fingerstick component or knowing your blood sugar component, it can be through fingerstick blood glucose levels, or it can be through any number of the sensors that are available on the market. And the reason it's important to take a moment to take stock of how diabetes management in type 1 can be done is because there's a couple of notable factors. First is that disparities exist in type 1 diabetes across this entire spectrum when it comes to adults in America. Some don't even have regular access to insulin, and that's problematic. And when we look globally, the same inequity across the entire field. There are colleagues I have in Nepal, in India, in sub-Saharan Africa, in any number of countries that are less resourced than America, where my colleagues are making decisions off of one test strip every few days. In pediatrics, which is where I primarily sit, the disparity primarily emerges in diabetes technology. And the reason is because of the somewhat universal health care. There's a lot of safety net coverage for insurance for pediatric patients that gives them access to insulin and fingerstick blood glucoses, but does not give them access to consistent access in its application. There might be by the letter of the law, it's available, but how it's actually executed, there are clear and long-standing disparities, and that's what we'll cover today as well. So the first question is, okay, so there's a large swath of the population that appear to have unequal access to diabetes technology. Does that matter? And the short answer is yes, it does matter, because it appears that diabetes technology improves hemoglobin A1C. And this is, again, type 1 diabetes exchange data looking at 2016 to 2018, so pretty recent, looking at our more recent technologically robust sensors and pumps. And you can see here that if you are a pump user across the lifespan, starting at 5 years all the way to 75, you are more likely to have a lower A1C. The same goes for if you are a pump user and CGM user here. That across the lifespan, you will have improvements, or there's an association with improved A1C in those who use diabetes technology than those who don't. And hemoglobin A1C is the long-term marker for complications, so that the hemoglobin A1C that is more in range, in the target range that we would like, is associated with fewer long and short-term complications, improved quality of life. And much of what we'll be discussing broadly in this conference includes the time in range, and time in range and A1C have a strong association and correlation that's been well described. Next is coming to sort of documenting, right, quantifying the inequities that currently exist. And A1C disparities exist by income across the lifespan. So there's two ways in America that we can look at that. One is by the annual income, and you can see that if you make less than 50K, your A1C is almost 1.5 to 2%. As for example, a 15-year-old. So there is clear across the lifespan differences. Mean A1C here is on the left-hand side, and then this is age. And the same thing for insurance. Private insurance is here in green, and public insurance is here in black, and no insurance is here in blue. And you can see again A1C on the left-hand side, and then age across the lifespan. I think there's an interesting commentary here, which is that you can see this relationship seems to uncouple here in this blue line of no insurance right up until about age 26, 25. And so this likely has something to do with the universal coverage that's, like I was mentioning, relatively universal, as long as you are typically at least documented. There are certain holes, right? So I don't want to undersell that. There are holes to pediatric diabetes coverage as well by insurance, but it's more complete than our adult counterparts. And so you can see that relationship between insurance and also the A1C starts to uncouple a bit, which may have to do with our coverage policies. To try to understand the role of not just income, but socioeconomics as a whole, there was a study that with our German colleagues that we undertook, where we compared the Type 1 Diabetes Exchange, which is a registry data from America, and the DPV, which is a nationally representative German data, both looking at individuals with type 1 diabetes. In our case, we decided to look at youth to try to understand what is the relationship between socioeconomics and insulin pump use, CGM use, and hemoglobin A1C. For the T1D exchange, we equally weighted the parental education, the insurance type, and then the annual income to come up with a socioeconomic number, and then those were categorized into quintiles. For the DPV, there's an area deprivation, which looks at income, employment, education, the revenue of the neighborhood, and each are weighted slightly differently. And then each record was given a value, and then they were sorted into quintiles. So this is sort of what I mean. Like I said, for the Type 1 Diabetes Exchange, we looked at the parental education of the highest parent, insurance type, and then annual income, and then sorted them into 5 quintiles. And then here, we first looked at pump use. There were 2 separate time periods that we looked at, 2010 to 2016, approximately. And what we can see here is, looking at the American data, quintile 1 is the highest socioeconomic quintile, and quintile 5 is the lowest. And you can see that across all the socioeconomic groups, it is true that there has been an uptake from the earlier years here in light blue to the darker years. But you can also see that the highest use is in those of the highest socioeconomic status, and the lowest use is in those of the lowest socioeconomic status. And Germany, which is an economically comparable country, when we look at their data, there is a pretty impressive lack of relationship between socioeconomic status and pump use. And just like in America, there was an increase in all of the quintiles, but you can see that strong socioeconomic relationship that we see here doesn't seem to exist here in Germany. Now, moving to continuous glucose monitoring, it won't surprise this audience that between 2010 to 2012 and 2016 to 2018, there has been a marked increase in CGM use. The devices are generally more accurate, they're more comfortable, they don't require calibration. There's multiple reasons why there's likely a strong uptake. It's now also recommended in all of the national guidelines as a major consideration for how to monitor blood glucose levels. What I'd like to draw your attention to, though, is the fact that you can hopefully appreciate that the increase in CGM use is in those of the highest socioeconomic status. You can appreciate that there's a preferential uptake when you compare those of the lowest to the highest. So that's why the slope of the line is more steep than it was before. While here there's been approximately a 10% increase, 10 to 15%. There's almost a 40% increase here of the highest socioeconomic status. So what we found is that CGM use was preferentially uptaken by those of the highest socioeconomic status. And again, this strong socioeconomic trend is just not seen in Germany. And just like you've seen in America, you can see that there was low uptake in 2010 to 2012, and then there is a significant but relatively equal across the quintiles uptake in Germany. And as I've noted, CGM use, pump use is associated with A1C. So the question is, how is the relationship between socioeconomic status and HbA1c? And you can see here that there is the 2010 line where there's a strong socioeconomic relationship. And again, hopefully you can appreciate that there's been kind of a preferential worsening of youth with youth from the lowest socioeconomic status. I'm going to click back for a second and just make a very important acknowledgement. It's true that across all 5 socioeconomic quintiles, American youth today are doing relatively poorer in their hemoglobin A1c values than they were at the start of the decade. But what I hope you can also appreciate is that the interval rise between the start and the end of the decade for those of the highest socioeconomic status is much lower than the interval rise of almost one hemoglobin A1c point in the highest socioeconomic quintile. And once again, in the DPV, not only do you notice, again, a few major take-homes, in general, their A1C is significantly lower to begin with, and what they have done is, at the start of the decade compared to now, their hemoglobin A1C has overall improved and not worsened like it has in America. But you can see that it hasn't preferentially increased in one group than another between the two time periods. And then the last point I'll make is that there's still certainly a socioeconomic relationship here that's appreciated that isn't as robust or as strong as it is in America, but is certainly present. And so the question is, why? Why are there these drivers of disparities? And the fact that they impact hemoglobin A1C seemed a good place for us to look. And what we did was this is that same figure we just looked at, and we said, okay, so this is the A1C curve here, where we've gotten intervally worse, but specifically, primarily in the highest socioeconomic groups, they've seen the highest rise in hemoglobin A1C. We know diabetes technology is helpful, so what if we statistically controlled for it? And what you see here is that still there's a socioeconomic relationship. I cannot underscore that enough. But what you find is this preferential worsening in the lowest socioeconomic group goes away. When you account for the role that diabetes technology plays, you have equal worsening across all of them. Now that's not ideal, but what that does do, right, these parallel slope lines, what they do is suggest an area for us to at least work towards a more equitable approach to addressing health inequity. So it seems like diabetes technology access and use is one driver of disparities in pediatric type 1 diabetes, which brings, it's each time you answer a question, there's another question that comes up, and the question is, well, why are there diabetes technology disparities? And there are a few reasons, and insurance is certainly a driver. There's a really elegant commentary that Anderson et al. Put out where they really just document the Medicaid coverage for continuous glucose monitoring use. And you can see that there's significantly more requirements, or even more challenging still, none at all. So you don't know quite how to address and make sure that individuals who need and want continuous glucose monitoring and have public insurance, that they are able to get the coverage that they would like. There's a lot of policy change that's happening too day to day, so it's also hard to keep up with the fact that there's variability between states, between counties, but also variability from time to time. And that's there are many individuals who will be in the audience who know the challenges of that. So to better understand the role of insurance as a driver, we looked at our data here at Stanford and looked just at those youth from public insurance, and we found that those who never use CGM had higher A1Cs than those who consistently use CGM. And we also were interested in looking at youth who discontinued because of their insurance status versus those who discontinued because of self-preference, things like on-body experience, skin irritation. And we were very interested in this cohort and really understanding them a little bit better, because these are all individuals who started on CGM, and although it wasn't statistically significant, we were interested in understanding this. There appeared to be a drift up compared to those who were consistent users. So to better understand this, we looked at 1,000 visits, and we looked at only those youth who started CGM, and the baseline was the CGM start A1C. And then we looked at the visit right after the CGM was started to see how did the hemoglobin A1C change. And so here on the y-axis, I just have a delta value, change in hemoglobin A1C from the CGM start. So that's the baseline. And then we categorized each visit. We called a visit uninterrupted CGM use if the youth had access to was using CGM both before, at the visit prior, and at the visit that we were evaluating. The initial loss of CGM was that the youth did not had CGM at the visit prior, but at the current visit there was no CGM available, either by decision or by insurance. The continued loss of CGM said that there was no CGM at the prior visit or at the current visit, and then CGM regained after a loss means that at the prior visit there was no CGM, but at the current visit there was CGM. We found that about 65% of our youth who fell in this kind of interrupted CGM, it was insurance mediated and not their personal preference. And when we look to understand how is it different for those kids who had uninterrupted use versus those who had any interruptions, there is a very impressive trend that emerged that if you have CGM access that is uninterrupted, then you have an improvement of 0.3% hemoglobin A1C. And you'll remember that 0.3% is something to write home about. But importantly, if you start losing CGM access, you don't just go back to zero. You don't just go back to where you started at baseline. It actually worsens. And it worsens that we sort of hypothesize it's because there's so much back and forth. Oftentimes, there are supply delays, there are logistical things. They have to meet a lot of onerous demands, and so our hypothesis is that really just makes it challenging for them to have a regimen that's reliable. And this isn't ameliorated if you're able to get CGM after it has been lost. So it seems that insurance plays a role, and hand in hand with insurance, which is part of the system, is provider bias. So I'm going to take a moment here to just define specifically implicit bias. So implicit bias is the unconscious and systematic discrimination or promotion of a subgroup. So many of us readily think of bias as attributing a negative quality to a subgroup. But it's equally important that the promotion of a subgroup is also technically a bias. It's a positive bias, but oftentimes the groups that we have a negative bias to are not the same groups that we have a positive bias for. An example is that you might be more likely to say, hey, I think this family is really information seeking, and they're very, I really want to make sure they have all of the possible cutting edge technology available to them. That in and of itself is not a problem, except that those individuals who are high socioeconomic status individuals tend to just generally have more information that's given to them, and those individuals who are of low socioeconomic status tend to have less information that's systematically delivered. The same goes by English speaking versus non-English speaking. The same goes for those who are non-Hispanic white versus those who are of any other racial ethnic group. So what ends up happening is while the systematic promotion of a subgroup is not inherently ill-willed, the end effect is that the same group is that there's a larger inequity between the two groups, because one group is systematically discriminated against and another group is systematically promoted. So rather than it just being one group going down, it's both a group going down and another group going up. And the reason that that's important is because that inadvertently plays into many of ours, not just providers, but many of our underlying assumptions and how we interact with others. And this shows up in providers because there is a meta-analysis that looked at whether providers have less empathy for from individuals from low socioeconomic groups. And the data and the studies for this meta-analysis range from 2005 to 2019. So they essentially took the pooled data of a specific survey called the Consultation and Rationale Empathy, or the CARE measure, which is a very commonly used and validated methodology to determine clinicians' empathy. And they looked at 18 studies with over almost 10,000 patients, about 9,700 patients. And they put this together in a forest plot analysis, which is typical of a meta-analysis, and they found that, providers tend to have less empathy for low socioeconomic individuals. And similar to this, I had worked with our faculty here to undertake the Gatekeeper Study, which nationally recruited providers. And we did try to get a good representation of physicians, APPs, and CDCESs. When this slide was made and when this study was being done, CDEs was the abbreviation that was used, so not CDCESs, but that's why this is a little out of date. And we, like I said, we recruited nationally. About half of our participants came from California, but the others were sort of all over the country. And what we did was we classified, again, anchoring on the fact that it's both the systematic promotion of one group and the systematic discrimination against the group. We had an a priori, sort of previously defined, before we even enrolled the study, definition of what bias was going to be. And bias in a provider was if they recommended diabetes technology to somebody with private insurance, and if they didn't recommend technology to somebody with public insurance. And what we found is that apologies for that, the light went off in the office. What we found was that, in fact, there we are, that those who were non-Hispanic white had a higher tendency towards bias, and those who were in practice longer years had a higher tendency towards bias. And now those of you who know and love statistics know that just looking across one variable isn't quite enough, and so we also did a multivariate analysis, and really the thing that emerged to be the most important, more than age, was the number of years in practice. We found that the longer you were in practice, the more likely you were to have bias, and this we think is primarily because of some of the insurance factors that we had talked about. So in closing, I'd like to take us through a thought experiment and to really anchor in the fact that disparities, they result from unequal and inequitable access to efficacious interventions. And a very non-medical but heartbreaking example is, you will probably recognize a picture of the Titanic, where there was a limitation in the efficacious intervention, right? The lifeboats that were built into the Titanic were not enough, which is much like our current healthcare system. And there was definitely an unequal and inequitable access, and where in the case of the Titanic, it was by class primarily, and where the likelihood of you surviving if you were in the highest class was much greater than if you were in the lowest, by a difference of almost 90%. And so this non-medical example of the Titanic and the way that we do care provision has long-standing and sort of far-reaching ramifications. For example, I just spent much of the data that I was discussing was around the fact that there's unequal and inequitable access to diabetes technology, including CGM. Now, there's a broad movement, and we'll continue to talk about it in this conference, to shift away from hemoglobin A1C to time in range. And you cannot assess someone's time in range if they don't have access that is equitable to diabetes, to continuous glucose monitoring, the fundamental tool required to do time in range. We've also noticed this with respect to COVID, where there are unequal outcomes to individuals by race, ethnicity, by socioeconomic status. We've noticed the digital health and digital learning divide. So there has been, telehealth is primarily how we have been communicating during, especially in the heart of lockdown. And there were individuals who, because of the way that the infrastructure and the digital divide exists, they weren't able to seek healthcare appropriately. The same thing goes for K through 12 education. I mean, truly, if you look across every possible sector, you will find that there are efficacious things that we could be doing, but there's unequal and inequitable access to it. And so what we're going to do next is think about how it is that our internal passions, the things that move us the most, can be utilized and can be flexed so that the efficacious tools, interventions, things have more equitable and more equal access. And that's what the next two speakers are going to be talking about. So I want to thank everyone for their attention, and we'll look forward to questions